Welcome to our comprehensive guide on cardiovascular rhythm disorders. These disorders encompass a wide range of conditions, from bradycardia to tachycardia, each with its own unique characteristics and implications. As healthcare professionals, it's important to have a deep understanding of these rhythm disturbances, including their underlying causes, presenting symptoms, and appropriate management strategies. Throughout this guide, we'll delve into the intricacies of these rhythm disorders, exploring their diverse manifestations and the pivotal role that electrocardiography, ECG, plays in their diagnosis. By the end, you'll be equipped with the knowledge and tools necessary to confidently identify and manage these conditions, ensuring the best possible outcomes for your patients. Let's embark on this journey together as we navigate the complexities of cardiovascular rhythm disorders and empower ourselves to deliver exceptional patient care. Welcome to Slide 2, where we'll explore bradycardia. Slow heart rhythms. Bradycardia refers to a slow heart rate, defined as less than 60 beats per minute, typically originating from the sinus node. While it can be a normal response to factors like sleep or athletic training, it can also result from impaired conduction through the atrioventricular AV node, leading to delayed or blocked transmission of electrical signals. There are different degrees of heart block associated with bradycardia, ranging from first to third degree AV block. While asymptomatic bradycardia may not require treatment, symptomatic patients may experience dizziness, syncope, or heart failure. In such cases, a pacemaker may be indicated, particularly in the context of acute myocardial infarction. Let's delve deeper into the nuances of bradycardia and its management. First up, we have sinus tachycardia, which is a rapid heart rate, typically above 100 beats per minute, originating from the sinus node. This is often a physiological response to factors like exercise, fever, or stress. Next, let's talk about atrial fibrillation, an irregular and often rapid heart rhythm originating in the atria. It can lead to symptoms like palpitations, shortness of breath, and an increased risk of stroke. Lastly, we have supraventricular tachycardia, a group of arrhythmias characterized by a rapid heart rate over 100 bpm, originating above the ventricles, often in the atria or atrioventricular node. Understanding these different types of tachycardia and their underlying mechanisms is crucial for accurate diagnosis and appropriate management. Let's explore further. When it comes to diagnosing tachyarrhythmias, the most important tool in our arsenal is the electrocardiogram, ECG. ECG findings can help us distinguish between supraventricular and ventricular tachycardias, guiding our treatment approach. Holter monitoring is another valuable diagnostic tool. This involves continuous ECG recording over 24 to 48 hours, allowing us to capture intermittent or asymptomatic tachyarrhythmias that may not be present during a clinic visit. Echocardiography plays a crucial role in our diagnostic workup. By evaluating the structure and function of the heart, echocardiography can provide important information about the underlying cause of the tachyarrhythmia, helping us tailor our treatment plan accordingly. Additionally, thyroid function tests are often performed as part of the diagnostic workup. Assessing thyroid hormone levels can help us identify hyperthyroidism as a potential reversible cause of tachyarrhythmias. By utilizing these diagnostic tools in a comprehensive manner, we can accurately identify the specific type of tachyarrhythmia and formulate an effective management strategy for our patients. When it comes to managing atrial fibrillation, we have several strategies at our disposal. Rate control. Our first goal is to control the heart rate. We achieve this using medications like beta blockers, calcium channel blockers, or digoxin. By slowing the ventricular response, we can improve symptoms and prevent complications. Rhythm control. In some cases, we may aim to restore normal sinus rhythm. This can be achieved through cardioversion, which may be electrical or pharmacological. This approach is especially beneficial for patients with new onset or acute atrial fibrillation. Anticoagulation. Because patients with atrial fibrillation are at an increased risk of stroke, anticoagulation therapy is often necessary to reduce this risk. This typically involves the use of blood thinners like warfarin or direct oral anticoagulants, DOACs. Ablation. For patients with symptomatic drug-refractory atrial fibrillation, radiofrequency ablation may be considered. This procedure targets and eliminates the arrhythmogenic substrate, helping restore normal rhythm and alleviate symptoms. By employing a combination of these management strategies, we can effectively control atrial fibrillation and improve patient outcomes. When it comes to managing supraventricular tachycardias, we have several approaches at our disposal. 1. Vagal maneuvers. We often start with conservative measures like carotid sinus massage or the Valsalva maneuver. These techniques can help terminate certain types of supraventricular tachycardias by stimulating the vagus nerve and slowing conduction through the atrioventricular node. 2. Adenosine. This rapid-acting antiarrhythmic drug is highly effective in converting supraventricular tachycardias to normal sinus rhythm. It works by transiently blocking conduction through the atrioventricular node, interrupting the re-entrant circuit responsible for the arrhythmia. 3. Antiarrhythmic drugs. Beta blockers, calcium channel blockers, or other antiarrhythmic medications may be used to control the heart rate or convert the rhythm in supraventricular tachycardias. These medications help stabilize the heart's electrical activity and restore normal rhythm. 4. Ablation. For patients with recurrent or refractory supraventricular tachycardias, radiofrequency ablation offers a definitive treatment option. This minimally invasive procedure targets and eliminates the underlying arrhythmogenic substrate, restoring normal cardiac rhythm and providing long-term symptom relief. By utilizing these management strategies, we can effectively control supraventricular tachycardias and improve patient outcomes. When it comes to ventricular tachycardia, VT, and fibrillation, VF, swift action is essential. Ventricular tachycardia. This rapid, organized ventricular rhythm can pose a serious threat to life and often necessitates immediate intervention. Treatment may involve administering antiarrhythmic medications to stabilize the heart's electrical activity or performing cardioversion to restore normal rhythm. Ventricular fibrillation. In contrast, ventricular fibrillation is a chaotic, disorganized rhythm that constitutes a medical emergency. Without prompt intervention, it can rapidly lead to cardiac arrest. Defibrillation is the cornerstone of treatment for ventricular fibrillation, delivering an electric shock to reset the heart's electrical system and restore effective circulation. Pharmacological therapy. For ventricular tachyarrhythmias, medications like amiodarone, procainamide, or lidocaine may be administered to control the rhythm, either alone or in conjunction with electrical cardioversion. Unsynchronized defibrillation is the primary approach for treating ventricular fibrillation, delivering a high-energy shock to the heart to terminate the chaotic rhythm. In cases of unstable ventricular tachycardia, synchronized cardioversion may be employed to restore normal heart function. By promptly addressing ventricular tachycardia and fibrillation with appropriate interventions, we can effectively manage these life-threatening arrhythmias and improve patient outcomes. Understanding the ins and outs of Wolff-Parkinson-White, WPW syndrome is crucial. Mechanism. WPW syndrome arises from an additional electrical pathway connecting the atria and ventricles, facilitating rapid impulse transmission and fostering the onset of tachycardias. Presentation. Individuals with WPW may encounter bouts of supraventricular tachycardia, ventricular tachycardia, or even face sudden cardiac death due to aberrant electrical conduction patterns. Management. The gold standard for WPW treatment is radiofrequency ablation, which eradicates the accessory pathway, thereby averting recurrence of life-threatening arrhythmias. Antiarrhythmic medications may offer interim relief while awaiting ablation or for symptom management. By comprehending the intricacies of WPW syndrome and pursuing appropriate management strategies, we can mitigate the risk of adverse cardiac events and enhance patient well-being. Understanding torsades de pointes is pivotal. Definition: torsades de pointes, a variant of polymorphic ventricular tachycardia, showcases QRS complexes swirling around the isoelectric line on an ECG, resembling a twisting ribbon. Causes: often linked with long QT syndrome, either congenital or acquired, attributed to medications, electrolyte imbalances, or other triggers. Management: swift action involves rectifying underlying electrolyte imbalances, ceasing culpable medications, and promptly administering intravenous magnesium sulfate. By swiftly addressing underlying causes and instituting appropriate interventions, we can mitigate the risk of adverse cardiac events associated with torsade de pointe. Understanding the landscape of bradyarrhythmias and pacemakers is crucial. Sinus node dysfunction: when the sinus node falters in automaticity or conduction, sinus bradycardia or arrest may ensue. Pacemaker insertion becomes essential to sustain a proper heart rate. Atrioventricular block: impairment in electrical impulse transmission through the AV node leads to delayed or obstructed conduction from the atria to the ventricles, necessitating pacemaker intervention. Pacemaker indications: symptomatic bradycardia, high-degree heart block, and select cases of acute myocardial infarction often warrant permanent pacemaker placement to ensure adequate cardiac function and mitigate associated risks. Understanding the classification and mechanisms of antiarrhythmic drugs is crucial. Class 1 antiarrhythmics: these drugs inhibit sodium channels, thereby slowing conduction and prolonging the refractory period. Examples include lidocaine, procainamide, and quinidine. Class 2 antiarrhythmics: beta blockers like metoprolol and esmolol are employed to reduce heart rate and manage ventricular response in atrial fibrillation. Class 3 antiarrhythmics: agents like amiodarone and sotalol extend the action potential and refractory period, offering efficacy across various arrhythmias. Class 4 antiarrhythmics: calcium channel blockers such as diltiazem and verapamil are utilized for rate control in atrial fibrillation and other supraventricular tachycardias. Navigating anticoagulation in atrial fibrillation involves several considerations. CHADS 2 score: this tool evaluates risk factors like congestive heart failure, hypertension, age, diabetes, and prior stroke, or TIA, to assess the need for anticoagulation. Anticoagulant options: warfarin, direct oral anticoagulants, DOACs, aspirin, or heparin may be prescribed based on individual risk profiles and preferences. Considerations: factors such as renal function, bleeding risk, drug interactions, and patient compliance influence the choice of anticoagulant. Close monitoring and periodic adjustments, particularly with warfarin, are essential for optimal outcomes. Synchronized cardioversion is employed to terminate organized tachyarrhythmias like atrial fibrillation or atrial flutter. This technique delivers an electrical shock synchronized with the QRS complex, aiming to restore normal sinus rhythm. Unsynchronized cardioversion is utilized for life-threatening arrhythmias such as ventricular fibrillation or pulseless ventricular tachycardia. Unsynchronized shocks are administered without synchronization with the patient's ECG. Pharmacological therapy may complement or substitute electrical cardioversion depending on the clinical context. Antiarrhythmic drugs such as amiodarone or lidocaine are commonly used in conjunction with or as an alternative to electrical cardioversion.